Hello, my name is Norman Curtis. Today is July 28th. For case connections for Unit 4, I did case number 1 and case number 2. So for case number 1, first question was to discuss the normal mechanisms of ammonia transfer in the body that should be occurring, including glutamate dehydrogenase, glutaminase, and glutamine synthetase. And be sure to discuss the role of transamination. So to start with, we've got amino acids that are broken down to their nitrogen component and their carbon skeleton. The ammonia that is released during this breakdown needs to be fixed and excreted, as it is toxic to the body, and this is done through the urea cycle. In the fasted state, the body will break down proteins to be used as an energy source. Typically, if we're taking in food and we're using those carbohydrates and other things as energy, we're not going to be breaking down proteins and breaking down amino acids for energy, because we don't need to. But in the fasted state, that's a pathway that the body needs to go down to produce energy. And proteins are essentially amino acid polymers. The amino acids travel from the tissues to the liver, where they are broken down to ammonia, which enters the urea cycle, and their carbon skeleton, which is used for ketogenesis or gluconeogenesis, depending on the structure of the amino acid. Either way, the amino acid is broken down to be used as an energy source, and in that process, ammonia is freed and enters the urea cycle to be excreted by the kidneys. Breakdown of amino acids is initiated by transamination. ALT and AST are common enzymes involved in this step. There is no release of free ammonia during these reactions, because the nitrogen component is being transferred and not released. As an example, AST converts aspartate to alpha-ketoglutarate, AST converts aspartate and alpha-ketoglutarate to glutamate and oxaloacetate. After transamination, a glutamate can then be deaminated by glutamate dehydrogenase to release ammonia and produce alpha-ketoglutarate, which is used as a substrate in the TCA cycle to produce ATP. So that's a big part of what we're talking about here, is the transamination is being done to create a intermediate of the TCA cycle, so that we can that's the idea, I guess, behind breaking down these amino acids for energy. So once glutamate dehydrogenase does its work, then we're able to use one of those substrates for energy production, and then the other, substrate that's created in that process is ammonia, and we're able to, take that up into the urea cycle and excrete it, so that it's not floating around in the body. Then we have glutamine synthetase. Glutamine synthetase fixes ammonia as glutamine and primarily functions in peripheral tissues as a way of ammonia detoxification. The glutamine can then be released into circulation, travel back to the liver, and be deaminated by glutaminase, which frees ammonia from glutamine. The free ammonium can then enter the urea cycle. So essentially, you've got the glutamine that needs to be broken down by glutamine synthetase, and then the glutamine is released back into circulation, travels back to the liver, and can be further broken down by glutaminase. The next question and part of case 1 was, how is nitrogen transport connected to gluconeogenesis in the fasted state? I kind of touched on this earlier, but so when we're in the fasted state, amino acids are broken down into the two basic components. One is their nitrogen component, which becomes ammonia that enters the urea cycle, and then the second component is the carbon skeleton of the amino acid, which is used as an energy source. And it can be used as an energy source in gluconeogenesis if the structure of the amino acid is appropriate. Otherwise, it's used in ketogenesis. And then in this individual patient, where acid levels are elevated, what urea cycle enzyme is most likely to be deficient, and what urea cycle enzyme is least likely to be impaired. So I chose ornithine transcarbamylase, or OTC, as being the likely deficient enzyme in this scenario. OTC converts carbamoyl phosphate and ornithine to citrulline, and then if OTC, if it's not functioning properly, that will lead to a buildup of carbamoyl phosphate, which gets converted to orotic acid via a pyrimidine synthesis pathway. And then citrulline levels are low because OTC is not making it in usual amounts. And then as far as the enzyme least likely to be affected would be the CPS1. CPS1 uses CO2 to convert ammonia into carbamoyl phosphate. If CPS1 were deficient, this would lead to low levels of carbamoyl phosphate and thus low orotic acid levels. With our patients' orotic acid levels being high, it makes it pretty apparent that CPS1 is not the one that is deficient. And then which amino acid, if any, becomes essential as a result of this deficiency? Arginine is synthesized via the urea cycle, and it is typically a non-essential amino acid. However, in our patient's case, the urea cycle is not functioning properly, so arginine is not being synthesized. So arginine becomes essential as a result of OTC deficiency. And then on to case number 2. There are 3 scenarios in case 2. So for each one, we'll talk about the most likely enzyme deficiency and which amino acids are no longer metabolized, if any amino acids become essential as a result of the deficiency, and then lastly, potential vitamin supplements that may be useful for the condition and what steps in the metabolism they could potentially help with. So the diagnosis for the patient in scenario number 1 is maple syrup urine disease. The deficient enzyme is the branched-chain alpha-keto acid dehydrogenase. The amino acids no longer metabolized include the branched-chain amino acids, which are valine, leucine, and isoleucine. As far as amino acids becoming essential as a result of the disorder, that doesn't happen in this case. And then as far as vitamin supplements go for maple syrup urine disease, some cases respond to high doses of thiamine, which is vitamin B1. So with the branched-chain alpha-keto acid dehydrogenase enzyme, thiamine is a cofactor for that. The cofactor for the reaction. So if we give high doses of that cofactor, thiamine, then that sometimes leads to a response for patients with this disorder. And then for scenario 2, the diagnosis is alkaptonuria. The deficient enzyme is homogentisate oxidase. And the amino acids that are affected here is the metabolism of phenylalanine and tyrosine. So, well, the metabolism of phenylalanine and tyrosine catabolic byproducts is affected. So those would be the aromatic amino acids. This disorder does not convert any non-essential amino acids to essential amino acids. And then for vitamin supplementation, so in this disorder, typically people restrict their intake of tyrosine and phenylalanine, but also supplementation of nitisinone. Nitisinone has shown promise as a potential treatment of alkaptonuria. Nitisinone prevents the conversion of tyrosine to homogentisic acid, thereby blocking the production and accumulation of HGA, or homogentisic acid. It does this by acting as an inhibitor to the enzyme 4-hydroxyphenylpyruvate dioxygenase. And then scenario number 3, the likely diagnosis would be phenylketonuria. The deficient enzyme is phenylalanine hydroxylase. The amino acid no longer metabolized would be phenylalanine. And in this case, because typically the breakdown of phenylalanine in a healthy patient would lead to the production of tyrosine, in this case, that doesn't happen properly, so tyrosine does become an essential amino acid for this patient that has the phenylketonuria. Supplementation of BH4 or tetrahydrobiopterin can be useful in some of these cases. I guess it would be similar to the thiamine supplementation in maple syrup urine disease, because BH4 is a coenzyme of phenylalanine hydroxylase and would aid in the breakdown of phenylalanine.